This conference will now be recorded.
So I hope and pray to Almighty God for your healthy life, and I ask you to read your daily lesson so that after overcoming this situation, by the grace of Almighty God, we can continue our course and curriculum in future. Today, I will discuss few questions on respiratory system, which was previously discussed with you. And today I like to discuss 10 questions about respiratory system. And you will read it so that you will in future get preparation over your course.
Next.
So first question on respiratory system. A man of 30 years presented with fever, cough, and severe breathlessness. So question was, what is your diagnosis? And you know the diagnosis is pneumonia. And second question was, write 4 important investigations for this disease. And the answered first investigation will be sputum for AB acid first bacillus and culture sensitivity of the sputum. And gram staining also. From gram staining, we can detect gram positive and gram negative bacteria. From culture sensitivity, we can detect the causative organism. Next investigation will be blood for decreased hemoglobin ESR. Here total count will be increased in case of bacterial infection. But if the total count is more than 20,000, then it indicates severe pneumonia. Our next investigation is extra chest, where we will get features of consolidation, that is opacity with PR bronchogram. And last investigation is serum urea level. If it is more than 7 millimole, that indicates severe pneumonia. And this is the investigations of pneumonia. Now the treatment. And first of all, you should send the sputum for culture sensitivity test and start treatment with empirical antibiotics. And the empirical antibiotics are coamoxiclav, azithromycin, clarithromycin, and injection ceftriaxone. And the route of administration depends upon the patient's severity of pneumonia and patient ability to take orally or not. Total duration of treatment should be 7 days at least, and the treatment can be changed according to culture sensitivity report after 3 days. But if the patient has features of severe pneumonia that CARD 65 and score 4 to 5, then you have to send the patient for ICU treatment. So this is regarding the first question. Our second question, a 65 years male smoker presented with chronic cough, weight loss, and a cavity dilation in the chest. X-ray. First question is, mention the important causes. And the first answer of the first question is post primary pulmonary tuberculosis. Second is bronchogenic carcinoma. And our second question was the clinical finding and lab finding of this patient. Among the clinical finding, for tuberculosis, fever more than 3 weeks, and chronic cough with productive sputum, hemoptysis, weight loss, and weakness. This is the physical symptoms of tuberculosis. And the sign of tuberculosis is features of consolidation, that is bronchial pimpetus increased, percussion not dull, and bronchial breath sound present. And for tuberculosis, the lab findings yes are high, sputum for AP is positive, and X-ray chest show cavity dilation or consolidation. Tuberculosis positive, and expert test, gene expert test also positive, and ADA for tuberculosis efficient is also positive. For bronchogenic carcinoma, the symptoms are chronic cough, hemoptysis, breathlessness, chest pain, weight loss, and hoarseness of voice. And general sign, clubbing, and chest sign, movement of the chest restricted on the affected side, vocal pimpetus and breath sound diminished. Lab findings for bronchogenic carcinoma, sputum for malignant cell positive, may be positive, not always positive, and cavity lesion in the lung, and CT-guided FNAC from the affected site, especially from peripheral lesion, indicates bronchogenic carcinoma and type of carcinoma. And fiber optic bronchoscopy and biopsy confirm the central lesion and its histological type. Ultrasonography of the whole abdomen to detect the abdominal involvement, and CT scan of the chest to see the involvement of the mediastinum. Now treatment plan for pulmonary tuberculosis, you know, category 1 treatment for 6 months, and for bronchogenic carcinoma, for small cell carcinoma, the chemotherapy, doxorubicin, cyclophosphamide, vincristine, cisplatin, and etoposide. And non-small cell carcinoma, surgical treatment in case of stage 1 and 2, and radiotherapy for localized lesion, and chemotherapy also effective. So this is the treatment of bronchogenic carcinoma, and that is the end of question 2. Now question number 3. In known case of COPD, patient presented with severe respiratory distress. Examination reveals decreased expansion of the right side of the chest with mediastinum shifted to the left. So what is your diagnosis. Diagnosis is COPD with right-sided pneumothorax. And treatment of COPD will be oxygen inhalation 2 liters per minute, nebulization, injection Septiagen, and for pneumothorax, insertion of the IT tube in right fifth or sixth intercostal space along the right mid-axillary line and connected to water cell drainage. And keep IT tube for 24 hours or till full expansion of the lung. And the question number C of 3, question number 3C, 4 complications of pulmonary TB. One is proliferation, second is pneumothorax, third collapse of the lung, fourth fibrosis of the lung, and fifth disseminated TB and mediastinal lymphadenopathy. Now question number 4. A 20 years old female garment worker presented with history of fever for 2 months associated with dry cough. On examination, he had right-sided proliferation. So what is the possible diagnosis? The possible diagnosis is right-sided tubercular proliferation. Investigation, ESR will be high and X-ray chest will show homogeneous opacity in the right lung, obliterating the right costophrenic and cardiophrenic angle with curvilinear upper border. Pleural fluid aspiration analysis, color will be strong, AB positive in 30% cases, lymphocyte predominant, and biochemical test protein 3 gram and sugar reduced. Now treatment, anti-TB drug category 1 for 6 months and prednisone 21 milligram per kg body weight and 20 milligram 2 tablet for 1 month. So this is the answer of question number 4. Now question number 5. A 35 years old male presented with high fever, cough, large volume of foul smell, sputum for 6 weeks. So what is your clinical diagnosis? Our diagnosis is lung abscess. And the clinical presentation, general examination, high remittent fever, clubbing, chest examination revealed movement of the chest restricted on the affected side, bronchial perimeters increased. Percussion not dull, bronchial breath sound, vocal region increased, force capitation present. Now treatment, specific treatment. Sputum sent for culture sensitivity. Start treatment with empirical antibiotics like injection Septiagen 2 gram IV daily for 7 days or metronidazole 5 milligram IV 8 hourly for 7 days. And injection clindamycin. Second option of treatment is injection coamoxiclav 1.2 gram IV 8 hourly and tablet metronidazole 400 milligram orally 8 hourly for 7 days. And according to culture report, the drug should be changed after 3 days. And next 3 to 5 weeks, oral treatment should be continued. General measures, posterior drainage should be done, surgical treatment, if lung abscess not reduced after medical treatment. Now question number 6. A 65 years smoker, old man presented with significant weight loss, cough, hemoptysis, chest pain, breathlessness. On examination, anemia, clubbing, and cervical lymphadenopathy present. What is your clinical diagnosis? My diagnosis, clinical diagnosis will be bronchogenic carcinoma. And what will be the investigation? Sputum for malignant cell may be present ESR high, hemoglobin low, and X-ray chest may show consolidation or proliferation or capital dilation or deep destruction or elevation of the hemidiaphragm. Fiber optic bronchoscopy for central lesion to detect bronchogenic carcinoma and this histological type. CT-guided FNAC to detect bronchogenic carcinoma in peripheral lesion. Cervical lymph node excision biopsy to confirm bronchogenic carcinoma with metastasis. Principles of treatment. Treatment depends upon histological type. Chemotherapy in case of small cell carcinoma. Surgery in case of non-small cell carcinoma in stage 1 and 2. Radiotherapy in non-small cell carcinoma with localized lesion. Chemotherapy agents are injection doxorubicin, cyclophosphamide, vincristine, cisplatin, and etoposide. Now, question number 7. A 65 years aged patient of COPD admitted in unconscious state for 2 hours. His arterial blood gas reveals pH 7.25 and PO2 is 60 millimeter of mercury and PCO2 is 65 millimeter of mercury. What is your diagnosis? Diagnosis will be COPD with type 2 respiratory failure. Investigations are X-ray chest PA view, hypertranslucent lung field, tubercular heart, low flat diaphragm, and wide intercostal space. And spirometry revealed FEV1 80% of the expected value indicates grade 1, 50 to 80% of the expected value indicate grade 2, and 30 to 50 expected of the expected value indicates grade 3, and less than 30 indicates grade 4. COPD. Sputum culture to detect causative organism. Blood gas analysis indicates PO2 less than 60 and PCO2 more than 50 indicates type 2 respiratory failure. So this is the investigation. Now treatment. Treatment of very severe COPD with complications. Oxygen inhalation 2 liters per minute, 16 hours per day. If needed, mechanical ventilation in ICU. Nebulization with salbutamol 1 cc, ipratropium bromide 1 cc, normal saline 2 cc, 6 hourly. Injection ceftriaxone and injection orodaxan. Now question number 8. A 45 years male presented with chronic productive cough, sputum in copious amount, and usually warts in morning, and he had suffered from PT 10 years back. On examination, coarse crepitation and finger clapping present. What is your clinical diagnosis? Diagnosis is bronchiectasis. And cause of bronchiectasis is pneumonia, pulmonary TB, whooping cough. And complications of tuberculosis, bronchiectasis is hemoptysis, collapse of the lung, fibrosis of the lung, and cor pulmonale. Investigation of this patient is sputum gram staining and culture to detect causative organism. Blood leukocytosis is in pneumonia. ESR will be high in case of TB. X-ray chest show multiple ring-like shadow in lower zone of the lung, and multiple microabscess may also be seen. High resolution CT scan show multiple ring shadow if the X-ray chest is normal. And now treatment. Specific treatment, send the sputum for culture sensitive and start treatment with empirical antibiotics like coamoxiclav, ciprofloxacin, azithromycin, clarithromycin, and ceftriaxone. Change of antibiotics after 72 hours according to CS report, and duration of treatment will be 4 to 6 weeks. General measures: postural drainage. Surgical treatment Indication if medical treatment fails and single lobe affected. Type of surgery, lobectomy or pneumonectomy can be done. Now question number 9. A 30-year-old lady presented with fever, arthralgia and painful palpable dusky blue red nodule over the shin of the tibia. And what is your diagnosis? Diagnosis is erythema nodosum, and cause, what history will take? History of taking oral contraceptive pill and non-productive cough with dyspnea in case of sarcoidosis, and chronic cough, malaise, anorexia, weight loss for primary pulmonary TB. So these 3 are the common causes of your erythema nodosum. And investigation, ESR will be high and X-ray chest. In case of sarcoidosis, you will get bilateral hilar lymphadenopathy and multiple reticulonodular shadow in sarcoidosis, and unilateral hilar lymphadenopathy in case of TB. Skin biopsy confirm the diagnosis. And this is the last question of today's discussion. That is question number 10. A man of 55 years, smoker, presented with cough for 2 months, fever, hemoptysis, and examination shows finger clubbing. And here the diagnosis is bronchogenic carcinoma. And next question was mentions other 6 possible symptoms of this patient. And it is dyspnea, chest pain, anorexia, weight loss, fever, hemoptysis. So these are the 6 symptoms of bronchogenic carcinoma. And the common radiological presentation are consideration, proliferation, cavitar dilation, rib destruction, elevation of the diaphragm, and collapse of the lung. So we are at the end of today's question discussion session, and I think you will get some idea how to prepare your question answer, especially the university final Prof examination question. Today I have discussed 10 questions over the respiratory system. In the next week, if Almighty God help, we can discuss question about the cardiovascular system in the next week. I again hope your good healthy life and continue your daily study, so that in time we can complete the course and curriculum, and you can sit final Prof examination, especially the November batch.
Thank you, sir.
Tomader, have you any question?
No, sir.
No,
No, sir.
no, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
So
Thank you, sir.
we will meet you again. And again, I pray to God for your healthy life. Thank you.
Thank you,
Okay,
sir.
sir. Assalamualaikum, sir.
Assalamualaikum.
Thank you.
Thank you, sir.